Yeah, I'm going to talk about this new niche of interventional echo, which is an interesting thing, and I kind of fell into it in a funny way. So, I finished my cardiology fellowship in 1986, and in 1987 did an interventional fellowship with Cindy Grinds, and for years and years I was one of the few people in the country who did echo and intervention. Well, I got a cataract at age 50. And I got scared of the radiation, so I started sort of backing out of the interventional world, and it became a natural thing for me to start doing these TAVRs and MitraClips and all this crazy stuff that's fun, and I love it. And I actually got trained on all those devices, so I'm trained to implant Sapiens. I'm not an implanter. I do the imaging part, but I know the devices. I know what the interventionalists are thinking, and it turns out here I am, 10 years later, and my radiation badge shows way more radiation exposure than it ever did when I was doing 10 or 12 stents a day. So that didn't work out so good. But I want to just show you a case, because it's really the MitraClip that started all of this, where the MitraClip is one intervention where you really have to have TEE imaging to do it. You couldn't possibly do it without. This is a 85-year-old retired urologist in our institution, beloved guy. We all know him, and have sent patients to him over the years. And now he has fairly recent onset of significant heart failure. He has a prior CABG. His grafts are all patent. Moderate Parkinson's, stage 3 kidney disease, and his STS replacement score, was 8.2. I think his repair was about 6. So he meets the criteria for being a guy that's at relatively high risk for having something done. And you can see, I think, is a pointer work here? Maybe not. But you can see clearly the flail P2 here. You can see systolic flow reversal in his left upper pulmonary vein. And so the first thing we do is take him to the lab and do a transseptal puncture. Now here's the anatomy. You see the SVC at the top, the IVC at the bottom, and sort of this little artificial thing here where the fossa is. And what we're going to do is take a bicaval view, which follows that blue line. And you can see on the image the tinting here. Let's see, is this the... I know there's got to be a pointer on this thing. The top? All right, well, right there. We're tinting right there. The idea here is, well, I'll show you in a minute, but you can watch this. You don't even need fluoro. You can actually do this. Well, you need fluoro to get your wire up, but then, you can pull down. Then we kind of switch views and do this view, which is cutting anterior to posterior, and we can stay away from the aorta here. The big fear everybody's always had doing transseptals is punching here into the aorta. Well, we can steer posteriorly. So this is all, pretty straightforward. And then we can take another view, which is really a 4-chamber view, and check our height. So we know we need 4 centimeters of height above where we're going to grasp the leaflet. So all this can be done very, very quickly. So here's our patient. Now, one of our mitral valve surgeons, Rob Smith, has learned to do this, and he does transseptals in an average of 3 minutes. He's so good at this. He really just looks at the TEE. I show him the curve of the needle. He drags it down into the fossa. He's really amazingly good at transseptals and learned it very quickly. So here we are. We come a little bit inferior here. We switch views to make sure that we're not aimed in an anterior way, but we're nice and posterior, as you can see right here. And then we switch to this 4-chamber view, and we can see, again, that our height is a good, 1, 2, 3, 4 centimeters. So we're good. So then we have to go and put this clip on and get it inserted. So the first thing we do is we basically take this large, what's called a surgeon's view from the atrium. We position the atrial septum right here, and you can see the dilator tip right here coming across. This is a wire in the left upper pulmonary vein. And very simply, we can just watch this all happen in real time. We then put the steerable guide in, and the steerable guide looks like this on echo. You don't want it hugging the aorta up anteriorly because the mitral valve's down here, so we center it directly into the middle of the atrium, and then we put the clip out and begin to turn the M knob on the clip, which steers it medially and actually down toward the mitral valve, which is at the bottom here. So this is the clip coming out of the guide and turning and moving down. And we do this very quickly. So we're now, able to do, when we first started doing it, it took us a long time, but we've gotten really good at this. We can now do cases in 20 minutes if there's simple cases like this one is. So we aim right at the pathology. So there you see the torn cord. We're aiming right at it in a commissural view, right at it. We want to split the color flow jet. That's kind of the idea here. So we turn that color on real quickly. We don't use it a lot, just make sure we're splitting the color flow jet. And then we have to orient the clip. So again, you can see here that the clip is kind of cattywampus here. That's a technical term in the cath lab. We actually want it to be perpendicular to the coaptation plane. And if you try to grab that way, you're not going to grab the leaflets completely, and you really can create more MR. So we just simply turn it. And clock is clock, counter is counter. You have to translate the torque. It's a simple maneuver. Any interventionalist knows how to do it. We orient this clip. We aim it right for the pathology. And then we have to grasp the leaflets. So now the really important part. So we open the clip. As we go in, I didn't show you this, but we typically go in that same 3D view, turn the gains down so that the leaflets disappear, and you can see that when you go in, the clip doesn't turn one way or another. And then we open it. The clip arm should be wide and even here, and you want both leaflets to fall right down into each of these sort of V-shaped areas here, right to here and right to here on both sides. And so we do that, we pull back, we can see that the leaflets are now captured, they're laying on the clip arms, then we're going to drop the grippers, that's the next step, here they come. Again, everybody here is now looking at the TEE, all eyes on this, make sure we have the leaflets deeply inserted and captured between the grippers and the clip arms. Then we close the clip, and when we close it, we want to see that the leaflets are inserted all the way in, that they're what we call up and over and down in. Notice the mobility is really restricted. That's an important component. And notice the MR is virtually gone. Switch views, the MR is virtually gone, so we're really happy here. And then we look on 3D again. We see a tissue bridge very nicely here. And our gradient is 2, always important to check that. And our pulmonary vein, which was reversed before, is now completely normal. That is very reassuring when you see that. You don't always see that. And so there's a lot of procedures that we guide now with echo. MitraClip is the one I put on top because echo is essential to that. You just can't do it without it. Watchman, honestly, I think we could do a Watchman device without TEE guidance. It's really, you can do that completely on fluoro, but we have TEE for that. TAVR, well, we now do them with transthoracic under sedation. You'll probably see a case like that here. TMVR, we've done 6 of those, 3 Fortis, 2 Tendines, 1 cardiac Q. We got another cardiac Q scheduled. You definitely need TEE for that. Neocord and Harpoon, we're starting that up. I'm the Echo Core Lab for Neocord, so we probably won't be an implanting site, but we will be an implanting site for Harpoon. Those are artificial cords done transapically. Have to have TEE guidance for that. And then Cardioband mitral annuloplasty, which is an interesting procedure. You have to have TEE guidance for that, and who knows what else. They're coming down the pike. So is it a new niche or not? The problem is that if you do interventional echo, your salary will be slightly more than your mailman, and unless your department chief wants to subsidize you. So it doesn't pay well. You know, you don't get paid to go in and stand there and do this. So the other thing is anesthesia is very good at doing this. I mean, our anesthesiologists are very skilled TEE operators, and they can do the procedural TEEs. So I'm not sure if it's a new niche or not. However, here's our solution to it. And our solution is a salaried structural heart echo person, and that's me. So I don't just do procedural echo. I have 3 valve clinics a week with our surgeons and interventionalists. We see all the patients together. So I do the pre-procedural TEEs and CT and other things. And this is really critical because, like Colin Barker just said, you don't want to go in the lab and figure out you don't need to be there. You need to figure that out before you take the patient to the lab. And so anesthesia really can't see the patients in valve clinic and do pre-procedural imaging to identify the appropriate patient. So we also do the intra-procedural imaging, but quite frankly, this is the part anesthesia can do and do very well. But then we also see the follow-ups after the procedure, and I think that's important too. When you're involved with the patient from before, during, and after, you really learn how these procedures work, including the complications afterward, and that's an important part. So I think there is a niche for this, and I think it is, best done if it's done this way. Thank you very much.